Hello and welcome. My name is Dr. Henry, and in this video, we are going to examine the 12 cranial nerves. Now, in most OSCE scenarios, you will be given a particular nerve to examine in a particular station. So they will not tell you to examine all the cranial nerves in an OSCE scenario. They will definitely pick some of them or pick one of them in a particular station for you to examine. But in this video, we're going to go over the examination of the 12 cranial nerves, all of them. Now, in each nerve, we're going to try to explain the theory about the examination. Then we'll go ahead to perform the examination itself, and then give you a sample documentation which you can use to present. Now, just take note that every exam you're going to perform, we have 3 different phases. We have the pre-exam, the exam itself, and the post-exam. Now, in the pre-exam, this is where you greet your patient, you introduce yourself, you take permission from the patient, then you perform your hand hygiene, and you properly expose and position the patient depending on the particular exam. So this is very constant for every exam you perform, be it cranial nerve examination or any other physical examination in an OSCE scenario. Then at the end of the exam, which is the post-exam, you will thank your patient, probably summarize your findings if time permits. So this is constant for every exam. But in this video, we're going through all these cranial nerves. We will not have to perform the pre-exam or post-exam, each of the nerves. So we'll just go ahead to introduce each nerve, then probably perform the examination. But just bear in mind that in an OSCE scenario, you do the pre-exam and the post-exam. So we'll go ahead to start with the first cranial nerve. So the first cranial nerve is the olfactory nerve. This is a purely sensory nerve for smell sensation. So it takes sensation from the nasal mucosa to the olfactory bulb. Now, this is often omitted in most cranial nerve examination, except the patient complains of anosmia, which is loss of smell. Some of the things that can cause anosmia are things like head trauma, which might lead to sharing of the olfactory nerves. So we also have things like frontal lobe tumors, Parkinson's disease, COVID-19, upper respiratory tract infections. Now, to test the olfactory nerve, first we are going to ensure that each nostril is patent. So we're going to ask the patient to sniff through each nostril to ensure that it is patent, then repeat it for the other. Then if it is congested, the result will be invalid. Now, if the nostrils are patent, we are going to use non-irritating scents to be able to test each nostrils. The normal response is that the patient should be able to perceive and correctly identify the scents. Okay? So can you please close one of your nostrils? Then try to breathe in through the other, sniff through the other. Okay, sniff out, breathe out. Good. Do it for the other one. Then sniff out. Good. So we have ensured that both nostrils are patent. Now we are going to use a non-irritating scent like soap, coffee, or anything to test each nostril to ensure that the patient can actually perceive the scents and identify the objects. So can you close your eyes? Then close one of your nostrils. Now I'm going to bring a set close to your nose. Try to identify what it is and tell me what it is. Okay. Can you perceive anything?
Yes.
What is it?
It smells like soup.
Okay, good. Then still close your eyes, then cover the other nostril. Can you perceive anything?
Yes.
Okay, what is it?
It smells like coffee.
So that is the normal response. The patient was able to perceive and correctly identify the odor with each nostril. Now, the abnormal response might be something like anosmia, where there is complete inability to smell. We can have what we call hyposmia, which is reduced ability to smell. Or we can also have parosomia, which is distorted smell perception. So these are some of the abnormal responses we can get, which will indicate the lesion of the first cranial nerve. So in OSCE, just try to test each nostril separate and try to use non-irritating familiar scents and ensure that the nostrils are patent first before trying to test the ability to perceive and identify the various scents. Now, the second cranial nerve is the optic nerve. So this is a purely sensory nerve which carries visual information from the retina to the occipital cortex. So the second cranial nerve, which is the optic nerve, is a purely sensory nerve for vision. In the examination of the optic nerve, there are 5 components. The first one is inspection. The second one is visual acuity test. The third one is the test for visual fields. Then test the pupillary reflexes. Then you end with fundoscopy. These are the five components of the examination of the optic nerve. Now, the first one, which is the inspection, you will try to check the shape and the size of the pupils. Then after checking the shape and the size, you check the equality of the pupils. They should be approximately equal in a normal patient. Then you also check for any obvious abnormality like ptosis. Then when you are done with the inspection, you head over to visual acuity. Now in visual acuity, we are trying to test the clarity of vision. Now the equipment or the instrument majorly used for this is the Snellen chart, although we can also use the Rosenbaum chart, but the instrument normally used for this is the Snellen chart. So in the Snellen chart, you position it around 6 meters away from the patient or approximately 6 steps away from the patient and ask the patient to close one of the eyes and read. The reason why the patient should close one of the eyes is because a unilateral problem of the eye can be compensated by the other eye. So when testing for the clarity of vision, you ask the patient to close one of the eyes and try to read. The Snellich chart is recorded in a fraction. Okay, something like 6/6. The numerator represents the distance at which the patient was able to read it, while the denominator represents the distance it will take a normal patient, a normal eye to be able to read it. So if you have something like 6/6, it means the patient was able to read it at 6 meters, and a normal person should be able to read it at 6 meters. Now, if you have something like 6/12, it means that the patient had to come closer at 6 meters to be able to read what a normal person can be able to read 12 meters away, which shows that the clarity of vision is reduced. I don't know if this makes sense. If you have something like 6/12, it means the patient, which is a numerator, read this at 6 meters. Now, for a normal person, the person can read that at 12 meters, which is even longer, okay? That means the patient's vision is actually reduced. So that's that for visual acuity. The next component is the visual field. Now, the visual field represents all the areas a patient can be able to see in the periphery when they focus their gaze at a particular point. Now, how to test this is you sit facing the patient at an arm's length, then ask the patient to cover their left or the right eye, or the one that is not being tested, okay? Then, sitting facing the patient, you wiggle your finger from in out. You test the outer upper, the outer lower, then the inner upper and the inner lower. So you wriggle your fingers from the periphery, bring it in, and tell the patient to tell you when they're able to see your hand. They should be able to see it at the same time as you. That's how you test for the visual fields. Now, this helps us to test for what we call hemianopia, which simply means loss of vision in half of the visual fields. Now, some of the types of hemianopia includes what we call bitemporal hemianopia, which affects the outer half of both eyes. Then we also have what we call binasal hemianopia, which affects the inner halves of both eyes. Then we also have what we call homonymous hemianopia, which affects same side on both eyes. Okay. Then we also have what we call quadrantinopia. So these are some of the types of hemianopia we have, or some of the type of eye defects which can be detected by these visual field tests. Now, the next component of optic nerve examination is pupillary reflexes. So these are involuntary responses of the pupils to different stimuli. Now, mainly, the pupil responds to either light or focus, which is also known as accommodation. So the two different stimuli which we will test are light and accommodation reflexes. So this helps to regulate the amount of light entering the eyes when the intensity of light changes, or when the eye tries to focus on a close object or a far object. The pupillary reflexes we will test are the light reflex and then the accommodation reflex. Now, the light reflex is the constriction of the pupil, which is elicited by increase in light intensity. Now, this protects the retina from excessive light and optimizes vision. So, testing the light reflex, we are going to test for the direct response, okay? Then we're also going to test what we call consensual response. Direct response is when you shine light on a particular eyes, the pupil is expected to constrict. Now, consensual response is when you shine the light on a particular eye, the pupil of the other eye, the contralateral eye, is also expected to constrict. That's what we call consensual reflex. Then we're also going to test what we call swinging light reflex. We are watching out for what we call paradoxical dilatation. What this means is, the expected outcome is when you swing the light from one eye to the other, the pupils should constrict. But in what we call relative afferent pupillary defect, when you swing the light from one eye to the other, the pupils dilate instead of constricting. Now, this actually indicates optic nerve damage. So when you shine the light on the both eyes, we expect that the pupil should constrict. Then the contralateral eye should also constrict, which is what we call consensual reflex. Now, in swinging light reflex, if the optic nerve of one of the eyes is damaged, when you shine the light on the normal one, it's expected to constrict. When you take the light to the abnormal eye, the optic nerve which is damaged will not be able to pick up on the intensity of light. Okay, so the pupil will actually dilate because it's not able to pick up the stimuli, which will cause dilation of the pupil instead of constriction. So that is what we test for in the swinging light reflex. So this is what we use to dictate what we call relative afferent pupillary defect, known as RAPD. Now, the next reflex is the accommodation reflex. This is where the patient looks at a distant object, okay, then try to focus on a near object. You will expect the pupils to constrict and the eyes to converge. So that's known as accommodation reflex, and that is the final reflex we will test. Then, when you are done testing all the reflexes, the final one is fundoscopy. That is if time permits, but in most OSCE scenarios, you will not need to perform a fundoscopy in the optic nerve station. Now, it's always good to actually mention that you would like to perform a fundoscopy, so the examiner will take notes that you know that fundoscopy should be part of the optic nerve examination. Now, we're going to go ahead and demonstrate all these tests. Like we said, the examination of the optic nerve, you start with inspection. So you try to sit at an arm's length facing the patient. So you are going to inspect the pupil for the shape, the size, then the equality of the pupil. Then you also check for any other abnormality, like ptosis or any other abnormality you can see. So you look at the two pupils. So the pupils are round and they look equal, and there is no obvious abnormality looking at the eyes, no nystagmus or any obvious abnormality. So after inspection, the next is visual acuity test. Now, like we said, in the visual acuity test, we will test it with what we call Snellen's chart. For testing the visual acuity, use what we call the Snellen's chart. But we're going to improvise with this. So the Snellen's chart should be 6 meters away from the patient. Now, most times, in most hospitals, the chart will be on the wall, then there'll be a stipulated distance where the patient will start reading from. But if there's nothing like that, you can improvise with your step. So when you take 6 steps, it's actually approximately 6 meters, okay? So you take approximately 6 steps away from the patient, okay? So 6 steps is approximately 6 meters. Then you tell the patient to read the smallest line, which they can read. So can you please read the smallest line, which you can, then tell the patient to close one of the eyes, then try to read with the other. Close the right eye with your hand, just occlude it. Then read the smallest one you can read. Try to read this.
E, D, F, C, Z, P.
Okay, then close the other eye. Then try to read it with the other eye.
E, D, F, C, Z, P.
Okay.
D, E, F, P, O, T, E, C.
Then cover the other eye and try to read.
D, E, F, P, O, T, E, C.
So you try to check the smallest one, which the patient can read. Now, the one he read is 6/6, which means the normal eye, like I said, the numerator represents the distance at which the patient could read it, which is 6 meters. Then the denominator represents the distance at which a normal person can actually read it, which is also 6 meters. So that is actually 100%. Now, if the patient is not able to read that, then tell the patient to go up and read. So when the patient goes up, reads a bigger one. The next one here is actually 6/7. The bigger ones actually means the visual acuity is reduced because the denominator is greater than the numerator. What it means is that what a normal person, like this 6/12, what it means is what a normal person can actually read in 12 meters, you can actually read it only in 6 meters, which means you have to come closer to 6 meters to be able to read what a normal person can actually read from afar, which is 12 meters. Okay? So when the patient is not able to read the 6/6, you can actually tell the patient to come up and read a bigger one. The smallest one the patient is able to read, that is the patient visual acuity test. Now, after visual acuity, the next one is the visual fields. Like we said, with the patient looking straight, you try to test the peripheral vision of this patient. So we're going to demonstrate that now. So we'll sit at an arm's length from the patient. When testing the left eye of the patient, tell the patient to cover their right side. Can you cover your right eye? Okay. Then I'll cover the same side, which is my left. Okay, then cover my left. Then when you see my finger, just say now. So I will wiggle my finger from the upper outer quadrant, the upper lower quadrant, the upper inner, and the lower inner. Okay, so when you see my finger, say now.
No.
Okay.
No.
Okay. Then don't try to cross your hand. Use the other hand to cover your eyes. Then do this. So just focus on me.
No.
Good.
No.
Okay. So then test the other eye. Do the same thing too. Then cover this eye. Then cover the other side. Then start from the upper outer.
No.
Good.
No.
Good.
No. No.
Okay. So you should be able to see it at the same time the patient sees it, which is actually the normal. So this helps us to detect what we call hemianopia. And like I said in the theory aspect, I told you the different types of hemianopia. If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it. The next thing we're going to test is the pupillary reflexes. Like I said, we have the light pupillary reflex, then the accommodation reflex. Now under the light reflex, we have the direct, consensual, and the swinging test reflex. So we're going to start with the light reflex now. So to test the light reflex, so you use your pen torch. Now you must not, now when testing for the light reflex, don't shine the light directly to your patient's eye. You bring it from the side, okay? You bring it from the side to test for both eyes. So can you please open your eyes? Okay, so we're going to start with direct. So in the direct, you are shining the light and then you are looking at that particular pupil to see the constriction. That's direct. Okay, it constricts, then do the same on the other eye. So bring it from the side in. Okay, So that's direct. Then in the consensual, you shine the light on one of the pupils, the way you examine the other pupil. Okay, then do the same on the other eye. Good. So that's the consensual. Then the final light reflex we're going to test is the swinging light reflex. So you swing it from one to the other while trying to detect paradoxical dilation in relative afferent pupillary defects. Normal response, which is constriction of both pupils, is what we detected. So that's it for the light reflexes. Now the final one is the accommodation reflex. Okay, so you tell the patient to look very far. So can you look at this wall? Just look far at the wall. Now try to focus on this pen. Try to focus on the pen. Okay, what you notice is the pupils will constrict and then the eyes will converge. Focus on this. So that's the accommodation reflex, which is a normal response. So that's it for the reflexes. Then after the reflexes, the final one is fundoscopy. Like I said, in most OSCE scenarios, time might not permit you to perform fundoscopy on the optic nerve station. So always try to mention it to your examiners that you will also like to perform a fundoscopy. Now, next group of cranial nerves we're going to test are actually three. We'll test them together because they perform the same function. So we're going to test the cranial nerve 3, cranial nerve 4, and cranial nerve 6. So which are the Oculomotor, the Trochlear, and the Abducens nerves. Now, these three nerves control the extraocular muscles. The cranial nerve 4 controls the superior oblique muscle. Then the cranial nerve 6 controls the lateral rectus, while the other extraocular muscles are controlled by the cranial nerve 3, which include the superior, the inferior, and the medial rectus, the inferior oblique, and the levator palpebral. So the cranial nerve 4 controls only the superior oblique, while the cranial nerve 6 controls only the lateral rectus. I always remember this with SO4, okay? SO4, so superior oblique by the cranial nerve 4, then the lateral rectus is controlled by the cranial nerve 6, then all other extraocular muscles are controlled by the cranial nerve 3, okay? So these help in the movements of the eyes. Just note that the superior rectus moves the eye up, the inferior rectus moves the eye down, the medial rectus abducts the eye, that it moves the eye in. Then the lateral rectus abducts the eye, that is, it moves the eyes out. Then the superior oblique moves the eye down and out, while the inferior oblique moves the eye up and out. Now, testing for this is we use what we call the H test for eye movement. We will sit at an arm's length from the patient, then ask the patient to keep their head straight. They should not move their head, they should only move their eyes, and they try to follow our finger while we make an H sign. So this will enable them move their eyes, try to follow our hand movements. So we'll make the H sign. So that's how we test for this group of cranial nerves, and we're going to demonstrate it now. So sir, okay, just keep your head straight. Now only move your eyes. Don't move your head, just your eyes, and try to follow my hand, okay? So we'll make the H sign on the air. Okay, just follow my hand with just your eyes. Just follow it. So with this, we've been able to test for the cranial nerve 3, cranial nerve 4, and cranial nerve 6 together. Now, if there is a cranial nerve 3 palsy, okay, if there is a lesion of the cranial nerve 3, the eyes will be down and out, okay, and the pupils will be dilated also, because you know the cranial nerve 3 is also the efferent nerve that helps constrict the pupils. So the pupils will be dilated if there is cranial nerve 3 palsy, specifically cranial nerve 3. Then the eyes will be down and out, and there will be ptosis of the eyes. So, but if there is cranial nerve 4 palsy, remember the cranial nerve 4 palsy innervates the superior oblique, so it'll be difficult in looking down and in. So in the cranial nerve 3 palsy, the eyes will be down and out, okay? Then in the cranial nerve 4 palsy, there'll be difficulty looking down and in. Whereas in cranial nerve 6 palsy, which innervates the lateral rectus, the patient will not be able to abduct the eye. Now, while you're checking for the extraocular muscles, also check for nystagmus, okay? Check if there's nystagmus, then if there is, check the direction, check if it is present during the primary gaze or at the extremes. So that's it for the cranial nerve 3, 4, and 6. Now, the next cranial nerve we're going to talk about is the trigeminal nerve. Now, this has both sensory and motor functions. Now, it is called trigeminal nerve because it has 3 major divisions. So the 3 divisions include the ophthalmic division, which innervates the forehead and the upper lid, the maxillary division, which innervates the cheek, the upper lip, and then the upper teeth. Then we have the mandibular division, which will innervate the jaw, the lower lip, the chin, and the lower teeth. Now, this mandibular division also has motor division, which innervates the muscles of mastication. So that is to say, the trigeminal nerve, which is divided into 3 branches, the ophthalmic, the maxillary, and the mandibular. The mandibular also has motor functions, okay? So in testing this nerve, we're going to test the sensory division, test the motor division, and we're also going to test some reflexes, which include the corneal and the jaw-jack reflex. Now, for testing the sensory division, we're going to perform the light touch first, which we will do with cotton wool. Gently touch each division, and then we can ask the patient if they're able to feel this on both sides. Then we'll also do that for the pinprick. Then we're using what we call a neurotip. We'll test each division, then compare the normal. We're also going to do what we call a pin trick, where we use a neurotip to test each division. Then we also test the temperature. That's if it is indicated, but most times the temperature can be omitted. That's for the sensory function. Then for the motor function, we're going to inspect the muscles of mastication. Then we're going to palpate and also do what we call power testing. Then for the reflexes, we are going to test the corneal and the jaw-jack reflex. So we're going to go ahead to perform the examination now. So like I said, we'll start with the sensory. So for the sensory, we'll start with cotton wool. The first thing you're going to do is that you're going to test it on a neutral place first, at least to ensure that the patient knows the feeling. Then before you go ahead to test the areas you really want to test. That is for any time you want to perform light touch, be it this trigeminal examination or any other examination at all, try to touch it at a neutral place where the patient can feel the sensation and know the type of sensation they want. Then tell the patient to close their eyes while you go ahead and test for other places. So please, sir, can you open your first button? Okay. Can you feel this?
Yes.
Okay, now you're going to close your eyes. Anytime you feel it, you tell me if you feel it or not. So close your eyes very well. Okay. Then we're going to test the ophthalmic, the maxillary, and the mandibular division. Okay. So start with the forehead. Can you feel this?
Yes, I can.
So anytime it touches you, don't prompt the patient. So just tell the patient, tell me yes anytime you feel it. Okay. And again, test both sides first. You don't just test both the divisions of one side, then you go ahead to test divisions of the other side. If you test the mandibular, the ophthalmic here, you test ophthalmic the other side. If you test the mandibular here, you test mandibular the other side. Okay. So whenever this touches you, tell me yes.
Yes. Yes. Yes. Yes. Yes. Yes.
Okay. So that is that for the light touch. Then for the pinprick, we are supposed to use a neurotip. Anytime you feel this, just say yes. Close your eyes. So you prick the patients on the various divisions too. So we'll start with the ophthalmic.
Yes. 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 Yes.
Okay. So that's for the pinprick. Then the next is the check for the temperature. But most times, that's if it's indicated. But most times we skip this. So the sensory, we've done the light touch and the pinprick. The next, now for the motor components, we're going to inspect, palpate, and perform what we call power testing. Now, the first step is to inspect the muscles of mastication. Okay, so you just look at the patient. So you're trying to inspect for any wasting in the face, any wasting along the muscles of mastication, like the temporalis or the masseter muscles. Okay, so if there's no wasting, then you go ahead to perform the palpation. You tell the patient to clench their jaw or clench their teeth. Clench your teeth like you want to chew something. Then you palpate the temporalis muscle. Okay, then continue clenching. Then you palpate for the masseter muscle. Okay. Okay, so when you're done palpating, the next step is to perform what we call power testing. So you tell the patient, open your mouth, but don't let me close it. Open your mouth, don't let me close it. Okay? Okay. So with this, we are trying to test for what we call the lateral pterygoids. Okay, so try to close the mouth against resistance. The next is you try to open the mouth against resistance. In this case, you are testing for the masseter, the temporalis, and the medial pterygoids. Okay, close your mouth. Don't let me open it. Okay, so trying to open the mouth against resistance. Now you're going to test for the lateral movements by the pterygoid muscle. So you tell the patient to open their jaw, then try to move it by the side against resistance. Now open your mouth. Try to move it to the left. Okay, don't let me push it back. Okay, let's do this side. Then try to move it to the right. Don't let me push it. Okay, so with this now, we've tested the lateral movements, the pterygoid muscle. So by trying to move the jaw to the side against resistance. So tell the patient to open their mouth, then try to move the jaw to one side, then hold it, testing it against resistance. So we tested the motor components of the trigeminal nerve. The final one is the corneal and the jaw-jack reflex. Now for the corneal reflex, you're supposed to get a cotton wool, then test the cornea. Okay, so you're going to get a cotton wool and test the cornea. The normal response is that the patient should blink, which is a normal reflex. It should be, but we're not going to perform that. That's not always performed in routine OSCE examinations, but it's good you mention it, that you would like to test for the corneal reflex. Then the next final one is the jaw-jack reflex, okay, which you will do with your tendon hammer. Okay, so the jaw-jack reflex, just tell the patient to open your mouth, just open your mouth and hang it like that, okay? Then place your finger, then try to.
If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need.
In the jaw-jack reflex, if there is an upper motor neuron lesion, the jaw-jack reflex will be exaggerated. But like we see, there's minimal or no movement during the jaw-jack reflex test. So we are done with examining the trigeminal nerve. Now when you are reporting it, like in my patient, it's normal. So I can present it this way. Sensation is intact in all the three divisions bilaterally. Then the masseter and the temporalis bulk and power are normal, and jaw movements are full. So you can report it this way at the end of the examination. So we are done with the trigeminal examination. The next nerve we're going to talk about is the seventh cranial nerve, which is the facial nerve. Now this nerve has both motor and sensory functions. Now for the motor function, it controls facial movement and expression. That is to say, it innervates the muscles of facial expression. Now for the sensory movement, it is involved in tests of the anterior two-thirds of the tongue. That is for the sensory movement. It also controls the stapedius muscle in the middle ear. Now the function of this stapedius muscle is to dampen loud sounds. That is to say, if there's injury to this nerve, to this function, it means that loud sounds will be very exaggerated instead of dampened. So in examination of the facial nerve, we're going to start by testing the motor function, then we're going to test the sensory function. Now in testing the motor function, we're going to start from inspection, then we'll test facial movements, then we're going to perform what we call the hypoglossal test, which we're going to test for the stapedius muscle, okay? So in the inspection, what we're looking for is facial asymmetry at rest, okay? So you look at the forehead, check if there are wrinkles, and if there are wrinkles, check if it's symmetrical across the face. Then we're going to check if there's any loss of the nasolabial fold. Then you also check for the angle of the mouth, check if there's any deviation. So we are essentially looking at the face to make sure that the face is symmetrical. Okay, so check the wrinkles on the forehead, check the nasolabial fold, then check the angles of the mouth for any deviation. So that is the inspection first. Then when you're done with the inspection, we're going to test facial movement, okay, by asking the patient to perform some actions for us. Then after that, we'll now test the function of the stapedius muscle, okay, to make sure that the innervation is still intact. Then after that, we'll go over to the sensory division. So let us start with inspection. Like I said, so we're going to start by inspecting the face, okay? You're supposed to face the patient. Then you're going to inspect the face. There are no wrinkles currently, okay? Then check the nasolabial fold. Check if there's any loss of the nasolabial fold on any side. So the nasolabial fold is intact. Then check the angle of the mouth to see if there's any deviation. If there's any injury to any side, the mouth will be deviated to the opposite side, okay? So there's no deviation from what I'm looking at. Then there's no loss of nasolabial fold, and there are no wrinkles on the face. So that is that for inspection. Then to test for the facial movements, we're going to divide it into the upper face and the lower face. Okay, so let us start from the upper face. Okay, to ask patient to try to look up without raising their head up. So try that, okay? So we're checking for wrinkling. Okay, so this wrinkling is symmetrical across the face. Okay, so in upper motor neuron lesions like stroke, the forehead will often wrinkle on both sides. Okay, the forehead will still wrinkle on both sides, so it is preserved. But in lower motor neuron lesions like in Bell's palsy, the forehead won't wrinkle on the affected side. Okay, so then again, we'll ask the patient, oh yeah, close your eyes very tight and don't let me open it. Okay, you try to open, okay, that's okay. So like when we try to open the eyes, we felt very strong resistance, which is what it should be. So the patient was able to close the eyes very tight and we're not able to open it. Now what we're looking out for is any weakness on any of the sides, okay? So if there's any weakness on any of the sides, in lower motor neuron lesions, there might be weakness on the affected side, but in upper motor neuron lesions, it will be preserved. The patient will be able to close their eyes very well. In upper motor neuron lesions, we have a saying for it, upper spares upper. So in upper motor neuron lesions, the patient will still be able to close the eyes very well on both sides. But in lower motor neuron lesions, the patient might not even be able to close the eyes at all. Or if the patient is able to close the eyes, we can easily open it when we try to open it. Okay, so that's that for the upper face. Now for the lower face, we're going to ask the patient to bare their teeth. Okay, smile and show me your teeth. Okay, so as they're showing your teeth, you observe the nasolabial fold, then observe the angle or the deviation of the mouth, the angle of deviation, or the angles of the mouth, okay? Check if it's symmetrical, okay? So, then puff out your chips like this. Don't let me bust it. Don't let me bust it. Okay? So when we ask the patient to smile or to bare their teeth, we are checking to see if the smile will drop on one side. Then we also check the nasolabial fold and also check the angle of the mouth. If there's any injury to the nerve on any side, the mouth will be deviated to the normal side. Okay? So that's that for that. Then we also tested the orbicularis oris by asking the patient to... So when we ask the patient to puff their cheeks, we'll try to press against resistance to see if air will escape, which we are not able to escape, so which is the normal response to that test. So through these tests, we have checked the upper face, which is the forehead and the eye closure. Then we also checked the lower face with the smile and the puffing of the cheeks, which are normal in this patient. So what you should know is, like I said earlier, in upper motor neuron lesions, upper spares upper, that is to say, in upper motor neuron lesions, the effect will only be on the lower side of the face. So the upper will be spared. But in lower motor neuron lesions, like in Bell's palsy, the effect will also be at the upper face and also at the lower face. Then again, since we are done with facial movement, so the next is what we call the hypoglossal test, where we'll test for the integrity of the nerve to stapedius. Okay? So what we'll do is we'll snap our fingers, okay, behind the patient and ask if they heard it, if there's increased sensitivity on any side. Okay? Can you hear this?
Yes.
Can you hear this?
Yes.
Is it increased on any side or is it the same on both sides?
It's the same.
Okay, same on both sides. Now, if there's any injury to the nerve to stapedius, the sound will be very, very exaggerated on that side because the stapedius muscle helps to dampen loud sounds. So that is that for the motor testing in the facial nerve. So the next is testing the sensory nerve. Okay, like we said earlier, the facial nerve carries sensory tests from the anterior to third of the tongue. So in OSCE scenarios, this is rarely tested due to time and other constraints. So it might suffice, just ask the patient, have you noticed any change in your test as of recent? Okay. Then if you are still going to test it, you can test it by applying solutions like sugar for sweet, salt for salty, lemon for sour, then quinine for bitter. Use something like a cotton applicator or a tongue depressor to apply these flavors once at a time at the tongue and ask the patient to identify it. That's how you test for the sensory division. But in most cases, asking the patient if there's any change in their tests can suffice in most OSCE scenarios. Now, when you're done testing the facial nerve, you can report it like this: facial movements symmetrical, full power in the upper and lower face bilaterally, no facial drop. Thanks. The next nerve we're going to talk about is the vestibulocochlear nerve, which is the 8th cranial nerve. Now, this vestibulocochlear nerve, like the name sounds, we have the vestibular division and the cochlear division. The vestibular division is for balance, while the cochlear division is for hearing. So in examining the vestibulocochlear nerve, we're going to examine both hearing and balance. Now, for the hearing assessment, we're going to start with what we call initial assessment. This is where you simply gauge if the patient actually hears you during normal conversations. Then you proceed to what we call the whisper test, where you will try to stand behind the patient and then whisper something while closing the other ear. Okay, whisper something to gauge if they can hear you. Okay, you go ahead to perform some tests with tuning forks. So like I said, we'll start with initial assessment, then whisper tests, then we'll go ahead to perform some foot tuning fork tests, which include the Reiner and the Weber's test. So first, just converse with the patient to see if the patient can hear you normally. Yeah, good afternoon, sir.
Hello, good afternoon.
How are you?
I'm good.
Okay, so that's just initial assessment. So trying to gauge if the patient can hear you. Obviously, he can hear us. Then the next is the whisper test, where we'll stand behind the patient so that they can't read our lips. Then we'll try to whisper some words in their ears to see if they can hear. Okay, so to do that, we're supposed to stand behind the patient. We should move behind the patient, then try to close the other ear by apply tracheal pressure on the other ear, then whisper something in this ear to see if they can, to know if they can hear you. Okay, see. So tell me anything you hear. Tell me. 99.
99.
Good. So you apply pressure on this ear, then try to whisper the other ear. 34.
34.
Okay. So with that, we'll conclude the whisper test so the patient can actually hear us. The next component of this examination is the tuning fork tests, which we'll use a 512 Hertz tuning fork, okay, to perform these tests. So we have the Reiner's test and then we have the Weber's test. Okay, so these two tests will help us to test a hearing assessment. Now, let me explain it before we perform it. So air conduction is greater than bone conduction, and that is what we are going to test with the Reiner's test. Okay, so to perform the Reiner's test, you strike the tuning fork, 512, it must be 512. Okay, so you strike the tuning fork, then place it on the mastoid, just behind the ear. Okay, ask the patient if they can hear it. When you place it on the mastoid, what the patient is hearing is actually bone conduction. Okay, so if you place it behind the ear, bone conduction will be able to conduct the sound. Now, when immediately the sound stops, bring it out, then place it just before the ear. The patient should be able to continue hearing it. Air conduction is actually greater than bone conduction. That is, the patient should be able to hear it even after you remove it from the mastoid and place it behind the ear. Okay, so we're going to strike this and then try to perform the experiment. And again, when you're holding your tuning fork, try not to hold the prongs. Okay, just hold the handle. Don't hold the prongs of the tuning fork. So you can strike the tuning fork. Okay, when you strike it, you place it on the mastoid, then ask the patient to tell you when it stops. Ask them if they can hear it first, then ask them to tell you when they stop hearing it. When they stop hearing it, you bring it out, place it just before the ear for air conduction. Okay, so we're going to do that now. Can you hear this? Tell me when it stops.
Just start.
Can you still hear it?
Yes.
Okay, and that is positive Rhinus test. So we'll do that on the other ear. Can you hear it? Tell me when it stops.
Start.
Can you still hear it?
Yes.
Okay, so that is also positive for Rhinus test for both ears. Now, we're going to do the Weber's test. So in the Weber's test, you strike the tuning fork, then place it at the middle of the forehead. So when you place it at the middle of the forehead, you ask the patient where they hear the sounds more. Is it at the left ear or the center? The normal sound should be heard equally on both sides or centrally. If there is unilateral conductive loss, the sound lateralizes to the affected side. Now the reason for this is this. So we're going to strike this and place it on the forehead of the patient. Okay, can you hear it in the left, right, or centrally?
Both.
Okay, both, all right. So actually, when you strike this and place it on the head of the patient, it is being conducted by bone to both sides of the ear. So the normal is that the sound should be heard equally on both sides. Now, if there's conductive loss on one part of the ear, that is to say external sound cannot get into the ear, then during the Weber's test, this will be lateralized to that part of the ear because there's conductive loss. When the sound is lateralized or heard more on the ear with pathology, then we know that there's conductive loss on that particular part of the ear. But when the ear is lateralized to the unaffected ear or the normal ear, it means there is sensorineural loss in the other part of the ear. Okay, so that is to say the sound lateralizes to the affected ear or the ear with pathology, that there's conductive loss in that particular ear. But if the sound lateralizes to the normal ear, okay, then we know that there is sensorineural loss in the other ear. So that is that for Rhines and Weber's test. So both Rhines tests and then Weber's test are used together to determine if we have conductive loss or sensorineural loss. So both Rhines tests and Weber's tests are used together in same context to determine if we have sensorineural loss or conductive loss. So with this, we're done with the hearing division of the vestibulocochlear nerve. Now for the vestibular division, so we're going to perform first the Romberg's test. It helps to test for the vestibular division and the proprioception. Then we're going to perform gait assessment and then pass pointing test. So the three basic things we'll do: the Romberg's test, the gait assessment, and then the pass pointing test. This will help us to assess the balance function of the vestibulocochlear nerve. Now for the Romberg's test, you ask the patient to stand, put their feet together, and then close their eyes. So if the vestibular function of the cranial nerve is affected, the patient will sway. Okay, so you try to hold the patient, okay, to stand up. Can you stand up? Then put your feet together. Just turn this way. Put your feet together, then close your eyes. Okay, so that's the normal response. Okay, so if the vestibular function of the vestibulocochlear nerve is affected, then the patient will be swaying. Okay, because of the loss of balance. Okay, then you can open your eyes now. Then again, the next we're going to do is the gait assessment. So you can ask the patient to walk 10 steps and back. Then you can also ask them to perform what we call tandem walk, where they walk with their. So when they're done going, okay, ask the patient to go 10 steps and back. After that, they'll perform what we call the tandem walk. So where they walk their heels to their toe, okay, probably 10 steps and then back. Okay, so they perform for the gait assessment. The patient can go 10 steps and back. Then they'll walk with their heels to their toes for like 10 steps and then back. Okay, that's for the gait assessment. Then the final one, which I'm going to do, is what we call pass pointing test. Okay, so can you just stand up and face me? Okay. Now I want you to raise your finger up. Raise your finger up. Okay, then touch my finger. Touch my finger with your finger. Okay, now close your eyes. Raise your fingers up again. Then try to touch my finger with your finger without opening your eyes. Try to locate my finger without opening your eyes. Okay, so if there is loss of vestibular function, the patient will not be able to locate your finger due to loss of balance. So that's what we call the pass pointing test. But in most OSCE scenarios, you might not even need to test the vestibular function, except the patient complains of vertigo or dizziness. Okay, so with this, we are done with the vestibulocochlear nerve.
If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it.
Now we're going to talk about the cranial nerve 9 and 10. So we'll talk about these two together because they do the same thing. They both innervate the pharynx and the palate. So we're going to talk about it together. And that is the glossopharyngeal and the vagus nerve. So that's the cranial nerve 9 and cranial nerve 10. Now, to test for this, we'll first of all test for the voice, check the swallowing reflex, check the palatal movement, and then check the gag reflex. So that is how we'll test for the vagus and the glossopharyngeal nerve, which are cranial nerves 9 and 10. Now, for the voice assessment, like I said, we'll start with the voice. We're going to listen to the patient's voice. If the voice is hoarse, that can indicate vagus nerve injury. Then again, if we have something we call nasal voice, then it can mean that there is palate paralysis. Or if you have weak or breathy voice, that might be what we call general laryngeal dysfunction. So we're going to listen to the patient's voice. So we can do that by trying to converse with the patient. Hello, good afternoon.
Good afternoon.
How are you today?
I'm good.
Okay, so the voice is normal. So by just trying to converse with the patient, we've tested the voice, okay, and the voice is okay. So next is the swallowing reflex or the swallow test. So we're going to ask the patient if they have any difficulty swallowing before. Then if there's no difficulty swallowing, you can give them a cup of water to try to sip and watch them swallow. Now when they're swallowing it, just observe for it something like coughing, regurgitation through the nose, or multiple swallows for one sip, which can indicate a weak pharynx. Okay, so give them something to swallow, then watch out for something like regurgitation or coughing or multiple swallows for one sip, which can indicate a weak pharynx. So we're going to give them something to swallow. Sir, please, have you had any problem with swallowing recently?
No.
Okay. Please, can you help me just take this water, just a sip? Okay. Okay, the patient was able to swallow it in just one gulp. So that's the swallowing test. So give the patient something to swallow. Okay, then watch, like I said, watch out for either coughing, regurgitation, or when they try to swallow just a single sip, the multiple swallows. Okay, that's that for the swallowing test. The next is the palatal movement. So we're going to use the pen touch for good visualization. Then we'll ask the patient to open their mouth wide, probably say something like ah. Then we're going to watch the position of the uvula and the movement of the soft palate. Now, in the normal response, the palate should rise symmetrically on both sides, and the uvula should stay midline. If there's a unilateral vagus nerve lesion, the palate will only elevate on the intact side, and the uvula will deviate towards the normal side. This is in contrast to what we'll see when we get to the hypoglossal nerve, where the tongue actually deviates towards the side of the lesion. So in the uvula, it will deviate towards the normal side, but in the tongue, it will deviate towards the side of the lesion or towards the abnormal side. So note that. So the uvula deviates in lateral vagus nerve lesion. The uvula will deviate towards the normal side, away from the lesion. Okay, so the palate will elevate on the intact side. So now we're going to use the pen touch and test the palatal movement of this patient. Okay, can you say ah?
Ah.
Ah. Put your tongue down. Ah, ah.
Ah.
Okay. So what I observed is a normal response. The palate rises symmetrically on both sides, and the uvula is midline. And like we said earlier, if there is a unilateral vagus nerve lesion, the palate will only elevate on the intact side, the uvula will deviate towards the normal side, away from the lesion. If there is bilateral weakness, then there will be no elevation of the palate on any side, and there will be something we call nasal speech. And there will be a risk of aspiration in that case. So with this, we've tested for the voice, the swallow, the palatal movement. Final one is the gag reflex. Most times, just mentioning that you perform the gag reflex will suffice in an OSCE scenario because it's not performed most times because of how uncomfortable it is. Okay? But if you're going to perform it, try to warn the patient that they're going to test gag reflex by touching the back of their throat. It may be uncomfortable for them. So try to warn them that you do that. And if you're going to do that, you're going to use what we call a tongue depressor or the tip of a cotton swab. Then gently touch the posterior wall or the tonsillar area of the patient. Then test both sides separately and observe for pharyngeal contraction. The normal response is that there will be a brisk contraction of the pharynx, okay, and a brisk elevation of the palate, and the patient will gag. The abnormal response is absence of gag, which could mean a lesion of either the cranial nerve 9 or cranial nerve 10. And it can be normally diminished in certain individuals. So take note of that. So that is that for the cranial nerve 9 and 10. So when you're done examining, you can just report it this way. The voice is normal, palate elevates symmetrically on both sides, the uvula is central, and gag reflex is present bilaterally. So that's that for the cranial nerve 9 and 10. The next cranial nerve we're going to talk about is cranial nerve 11, which is the accessory nerve. Now, this cranial nerve gives motor innervation to the trapezius and the sternocleidomastoid muscle. Now, the trapezius helps in elevation of the shoulder and the scapular movements, whereas the sternocleidomastoid muscle helps in head rotation to the opposite side. Okay, so the sternocleidomastoid muscle on the right will help rotate the head to the left. So these muscles are innervated by the accessory nerve or the cranial nerve 11. Now, testing for this, we'll start with inspection. Okay, so in the inspection, you will look out for muscle wasting in the trapezius, then check out for shoulder symmetry because the affected side may drop. So check out for shoulder symmetry, then check the contour of the neck. So in inspection, you are going to check out for muscle wasting in the trapezius, check the shoulder symmetry, check the neck contour. So then when you're done with the inspection, you test the trapezius by asking the patient to shrug their shoulder against resistance while try to push it as hard as possible. Then after that, you test the sternocleidomastoid muscle by telling the patient to turn their head against resistance. So we're going to do that now. So we inspect, then test the trapezius, then test the sternocleidomastoid muscle. Okay, so starting with the inspection, like I said, we are looking out for the wasting of the trapezius. We're also looking out for the shoulder symmetry and checking out the contour of the neck. Okay. Okay. Then when we are done with that, we will now test for the trapezius by asking the patient to shrug the shoulder against resistance while we apply downward pressure with our hands. So they should be able to resist you strongly. Note any weakness or asymmetry. If one side is significantly weaker, that indicates that the cranial nerve 11 has an issue on that side. Okay, so try to shrug your shoulder up against resistance. Okay, so they were able to resist me strongly on both sides. But if not any weakness or asymmetry, because if one side is significantly weaker, it indicates that there's a cranial nerve 11 issue on that side. So after the trapezius, you test the sternocleidomastoid muscle. Now here's an important note. The right sternocleidomastoid muscle turns the head to the left. The left sternocleidomastoid muscle turns the head to the right. So when you want to test for the right, okay, tell the patient to turn their head to the left against resistance while you palpate the sternocleidomastoid muscle on the right. Okay, so we're going to test for the right now, but by telling the patient to turn their head to the left against resistance, then we'll palpate with the other hand. Sir, can you please turn your head to the left against my hand? Okay, then while he's doing that, you palpate for the sternocleidomastoid muscle, okay, on the right. Then do the same for both sides. So when I try to test the left, tell the patient to turn their head towards the right. Okay, can you turn your head towards the right against resistance? Okay, then you palpate the sternocleidomastoid muscle. So the important thing to note is that if there is a cranial nerve 11 palsy, the shoulder will droop on the affected side. There will be wasting of the trapezius. There will be weakness in turning the head away from the lesion. Then there will be difficulty shrugging the shoulder. So these are things you must note. So when you're done, you can report it this way. So on examination of the cranial nerve 11, the trapezius and the sternocleidomastoid muscles bulk are normal. Shoulder shrug and head turning are strong bilaterally. So the last nerve we're going to discuss now is the hypoglossal nerve, which gives motor innervation to the intrinsic and most of the extrinsic muscles of the tongue. And in testing this, we are going to start by inspecting the tongue at rest. Then we're going to inspect the tongue when it is protruded. Then we're going to ask the patient to push their tongue against the cheek while we try to push it back. So to test the power of the tongue. We're going to end it by speech assessments. Okay, so these are the components of this examination. Now on inspection, we're going to tell the patient to open their mouth. They should keep their tongue inside, not protrude it. What you're looking for is any wasting on the tongue, which can be unilateral or bilateral atrophy. Okay, we look for a wasting, we look for fasciculation. We also watch out for any tremor or other involuntary movements. So at rest, we're going to tell the patient, open your mouth, but still keep your tongue inside. So we look out for any tremor, look out for any fasciculations, and also look out for any wasting.
If you found this video helpful, please drop a like, subscribe if you haven't already, and turn on your notification bell so that you don't miss the next one. Also share this with your friend who might need it.
Okay, so please, can you open your mouth? Just keep your tongue inside, okay? Okay, so we are done with the inspection. Then in the next step, which is the tongue protrusion, we'll tell the patient to stick out their tongue. We're going to observe for deviation. Now, I want you to note something very, very important. In the uvula, we stated that the uvula would deviate towards the normal side, okay? The uvula would deviate away from the lesion. But here, the tongue would deviate towards the affected or the weak side. So we'll call it that the tongue leaks the lesion. That's what we need to remember it. Now, we'll tell the patient to stick out their tongue, then we'll observe for any deviation, okay? And then note the strength and the steadiness of the protrusion. So please, can you open your mouth, then bring out your tongue? Okay, thank you. You can bring it in. So there is no deviation, okay? But if there's any deviation, it will actually deviate towards the side of the lesion. Now, when we are done with that, we're going to do the power testing. Where we'll tell the patient to push their tongue into their cheek, then we'll apply resistance from the outside. Try to push the cheek inside. So please, can you push your tongue on your left cheek? Don't allow me to push it in, okay? Then can you do that on this side? Push it out. Not allow me to push it in, okay? So with this, we are trying to compare the strengths of the two sides. So it should be strong and symmetrical, which is the normal response. So in the speech assessment, we are going to tell the patient to make some sounds, okay? So we're going to tell them to make the la sound, which tests for tongue tip elevation. Then we're going to make the da sound, which will test for the anterior tongue. Then I'm going to do the ta sound, which will test for the tongue precision. This is actually skipped in some OSCE scenarios, but for completion's sake, we're going to do that here. So please repeat after me. La 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 la. Okay. Okay, repeat after me. Ta da 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 da. Okay, repeat after me. Ta 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 ta. Okay. So the la 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 test for the tip of the tongue, elevation of the tip of the tongue. Then the da 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 test for the anterior tongue. Then whereas the ta 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 test for the tongue precision. Okay, so these require tongue movements. Now you're going to, as the patient is saying that, you listen for clarity of the articulation, the speed of the repetition, the consistency of the sound. When you're done with the examination, then you're going to document it this way. Maybe you can say something like, the tongue is midline with no wasting or fasciculations. There's no deviation on protrusion. Power is symmetric and strong bilaterally. Lingual articulation clear. Hypoglossal nerve intact. So that's an example of a report of a normal hypoglossal nerve examination. So this concludes our cranial nerve examination. Thanks.